Good morning and welcome to our panel, The Pandemic's Gift, What Life and Death Are About. My name is Beth Droppert and I'm the Vice Chair of Health Advocate X. Next slide. Today, we're going to be talking about three perspectives. I'll be speaking about how the pandemic changed thinking about end of life. And Dr. Gerda Meisel will be speaking about Advance Directives, and Janice Landis about healthcare surrogates. Next slide, please. We certainly have had a heightened awareness of death during this pandemic. And in order to understand that awareness, an organization called Better Place Forests conducted a nationwide survey of 1,138 Americans across all regions and across a variety of racial demographics to find out how the coronavirus pandemic is affecting attitudes towards end-of-life matters. The respondents ranged in age from 25 to 75 plus, and I just want to share some of the data that they found. Next slide, please. So the study conducted by Better Place Forests focused on how COVID-19 has changed the way we think and talk about death in America. And two notable trends that came out, not surprisingly, are that boomers are actually thinking more and talking about death, but most Americans are. So more people are also making end-of-life plans. And just to go over this, 48% of boomers say they're thinking more about their mortality since COVID-19. 37% of boomers say they're talking more about end of life, and 31% say they were already talking about it, as opposed to the millennials who say they're talking about end of life with their families more, 64% of them. 54% say they're thinking more about their mortality since COVID-19. Next slide, please. So who is talking about this more and who's making plans or not making plans? Well, not surprisingly, the older generation has a greater likelihood to be making these plans. So 83% of millennials have not finalized their plans for end of life. 79% of Gen Xers have not finalized their plans for end of life. And 63% of boomers have not finalized their plans for end of life. And having 30-somethings, I can say that they're more aware of this, but I can't say they're making their plans for end of life yet. Next slide, please. But of the people who have engaged in this conversation, a vast majority describe the experience as productive, reassuring, and positive. And many healthcare providers and community members now are acknowledging that advanced care planning conversations are important and essential. And actually, more recently, there's even reimbursement coverage to make sure that providers can cover their time when they have these conversations. Next slide, please. So we've not had control over many things during this pandemic, but we can have control over some things. And I love this statement: an end-of-life plan is a net for catching your anxiety and a lifeboat for holding your loved ones through their journey into the grieving process. Advanced care planning does provide a sense of control over health and future. Next slide, please. So what is advanced care planning? And this is according to an article by Andrew Saunderson about the reframing of advanced care planning. As Sador et al. Concludes, advanced care planning is a process that supports adults at any stage of health. And their primary goal of advanced care planning is to help ensure that people get the medical care that's consistent with their values, goals, and preferences. It's sometimes uncomfortable and uncertain, and people have a craving to feel a sense of control, particularly during times of crisis. And many people presume that advanced care planning is about considering and choosing medical treatments in advance. And yet, at the core of advanced care planning is really our values. Our values dictate most, if not all, of our choices and actions. Whether we are conscious or unconsciously thinking about it, our values influence what we wear, who we spend time with, what we eat, where we travel, what we listen to and watch, and what activities or events we engage in, especially right now during COVID. Similarly, our values directly inform what our healthcare decision-making is. So whether somebody chooses to pursue a surgery or a new medication or a tube feeding, those decisions are not merely made by considering the medical risks and benefits, but equally, if not more so, are chosen because of how somebody wishes to live as a result of that intervention. So advanced care planning is not about how we want to die, but rather how we want to live. Next slide, please. So rather than perceiving advanced care planning as merely about death and dying, many healthcare providers and community members now acknowledge the need to plan in advance for healthcare decisions, especially if we're not able to communicate or consent for ourselves. And rather than perceiving advanced care planning as difficult conversations, many healthcare providers and community members now acknowledge them as important and essential conversations. And rather than perceiving advanced care planning as primarily for the elderly or seriously ill, many healthcare providers and community members now acknowledge that we're all vulnerable and mortal and could unexpectedly become sick or injured. So therefore, advanced care planning is really of value for everyone. Next slide, please. So reflecting on and naming our values can often be challenging because values seem abstract to identify. However, medical professionals who are actively practicing advanced care planning have consistently observed how a few simple questions can help people discover and record what their values are. These questions can include, what does a good day look like? What brings you meaning and purpose in your life? And what brings you joy? Excuse me. These questions often turn into an unexpected yet valuable joy list, what highlights the things, people, places, and beliefs that are most important to you and bring meaning and happiness into our lives. A joy list, whether short or long, is a gift. It's a gift to patients, to their families, to healthcare providers, to those who are substitute decision makers or proxies. And it helps ensure that the healthcare decisions made align with who you are, how you want to live, and the joy lists are prioritizing your values, reminding the healthcare system that quality of life is equally as important as quantity of life. Next slide, please. While COVID-19 has turned so much of our world upside down, it has simultaneously provided a unique opportunity for all of us to reflect a little more on our values as we more intentionally consider what brings our life meaning and what brings us joy. Taking time to reflect on, record, and share our values is an imperative part of advanced care planning. So during a time when so many things feel out of control, uncertain, advanced care planning actually provides an invaluable sense of control over our health and our future. And now Dr. Gerda Meisel will discuss translating what we want into legal documents called Advance Directives.
I'm Dr. Gerda Meisel, and I'm here to talk about Advance Directives. Thank you very much for having me. An Advance Directive is a written statement about a person's wishes about their medical care. My job here today is going to be to give you some definitions and a little bit of commentary and advice around Advance Directives. Next slide, please. So as Beth so very nicely mentioned and did such a great job preparing us for this section, the pandemic, has changed how people are thinking about advance directive planning. They're feeling much more vulnerable. They often know somebody who had COVID, or they may know somebody who's recently passed away. And with visitor limitations in hospitals and rehabilitation facilities, there is often more formality now around who people will talk to, who healthcare providers will talk to. In the past, it was common for people to be able to access medical records. So let's say a reporter wanted to get a certain person's medical records. It wasn't that hard for them to do. Now, that kind of information is considered confidential and it is protected. Next slide, please. So let's talk about the parts of the Advance Directive. There are 3 different parts of the living will. There's the HIPAA release, which is what I just spoke about. There's the designation of a healthcare representative or a proxy. Now, there are multiple names for the healthcare representative or proxy. They can also be called the agent. They can be called the surrogate. They can be called the HCP. And sometimes they're referred to as the POA or power of attorney. But I want to caution you, there is more than one type of power of attorney. There is a financial power of attorney, and there is the healthcare power of attorney. The healthcare power of attorney is the same thing as the surrogate. And you may want to ask, when someone says that they are the principal, the person, the patient, power of attorney, you may want to check to see whether or not they are the financial power of attorney or the healthcare power of attorney. They're not the same, and people may deliberately intend to separate who can access their financial information and who can access their medical information. And the third part is the expression of wishes about healthcare, which is really a key part of any advance directive. Next slide, please. So we've touched on HIPAA, and what HIPAA does is it authorizes healthcare providers to release your private healthcare information to a specific designated third party. It protects the sharing of sensitive or confidential information without your consent or knowledge. It is a very good thing to have this in place, and people are much more conscious these days regarding privacy. Next section, please. So let's talk about the surrogate. Now, Janice is going to go into a lot of detail and information about surrogates, but I'll just touch on the key criteria. A surrogate has to be a competent adult. So you can't designate a 6-year-old as a surrogate. And the surrogate has to be willing to make decisions in the principal's best interest. Remember, the principal is the person who's making out the living will. And keep in mind that the principal's best interest is based on knowledge of that person's wishes. And sometimes what you think is right and what that person thinks is wants or thinks is right is not always the same thing. And you have to be willing, if you are serving as a surrogate, to respect that person's wishes. And often surrogates get involved towards the end of somebody's life. So if you're going to be a surrogate, you have to be prepared to handle end-of-life decisions. Next slide, please. So end-of-life decisions. Let's talk a little bit about it. They tend to fall into 2 fundamental buckets. One is discontinuing life-sustaining treatment, and the other is prolonging life as much as possible. Let's just talk about what a life-sustaining treatment is. A life-sustaining treatment is anything that prolongs somebody's life without reversing the underlying medical condition. So obviously CPR cardiopulmonary resuscitation, mechanical ventilation, those are life-sustaining treatments. But so is hemodialysis, antibiotics, nutrition, and hydration. And people may have different points of view on different aspects of life-sustaining treatment. People may also have different points of view on what kind of illness they have and whether they want their life-sustaining treatment discontinued. They may have a different point of view if they are deemed incurable versus irreversible versus having a degenerative illness. And I also just want to touch on the term prolonged unresponsiveness. Many people are familiar with the term persistent vegetative state. And in case you're not aware, we don't generally use that term anymore. We may say post-coma unresponsiveness or unresponsive wakefulness syndrome, because you can have a syndrome in what used to be called persistent vegetative state, where you're awake and the sleep cycles are now working. You're not in a coma where you have no awake sleep cycles. The person may be awake, but be completely unresponsive. And so that is sometimes called prolonged unresponsiveness, or what people used to know as persistent vegetative state. So there's a lot of different points of view that your clients may have around discontinuing life-sustaining treatment. Then around prolonging life as long as possible, that concept is often tied up with people's individual spiritual beliefs, their religious beliefs, their cultural beliefs. And some people just want to be alive in case their condition is curable, even if it's not curable today. Everyone is aware that medical science changes, and how things are in March might be different in the fall, where a new treatment may be coming down the road. So it's something that's very important to clarify. Next slide, please. The other part that's important to clarify around a person's wishes are fall into what I call invasive medical treatments. These are things, and we've touched on these, ventilators, PEGs. A PEG is a percutaneous endoscopic gastrostomy tube. That's the permanent tube in the stomach. Lines, dialysis, and less invasive treatments like antibiotics and pain. And people may have a variety of specific points of view on any of these treatments, and it's worth asking. And something that I want to make sure that I emphasize is that you simply cannot anticipate every situation. It's just not possible. Treatments change, situations change. And the best advice I can give to you if you're going to serve as a surrogate or if you're going to advise somebody is that the best thing to do is to have multiple conversations. With multiple conversations, both the person whose wishes are being recorded and the person who's going to serve as a surrogate will both have increased comfort and clarity. And I also encourage those wishes to be shared with others. I've seen situations where, for example, one daughter is the healthcare surrogate and the other one is not. And you get to the state where mom is going to need a feeding tube in order to survive. And one daughter, the non-surrogate, says, we can't not feed mom, we have to feed her or we're going to starve her to death. And the one who is the surrogate might say, but mom has been very clear she doesn't want a feeding tube. The more that everybody knows ahead of time what mom wants, the less heart-wrenching and difficult conversations have to happen at the bedside in a crisis situation. The other thing that I encourage people to talk about while they're on the topic are non-treatment wishes. Like, what do you want for your funeral? Do you want to be cremated, buried? Do you want to be next to Uncle Bob? You know, whatever it might be, people can have very specific wishes. Some people want to die, almost everybody wants to die at home, but some people feel very, very strongly about it. These things are worth considering. It's also good to know if the person for whom you're going to be a surrogate is an organ donor, because that might come up. Next slide, please. So I want to talk about the other type of advance directive where you can express your wishes. And this is a form called the MOLST or the POLST. It's called the MOST. It's called the TROP. It's got a lot of different names. But Oregon deserves credit because Oregon was the very first place where the POLST, which is Physician Order of Life-Sustaining Treatment, was put into place in 1991. my slides are labeled as MOLST, medical orders of life-sustaining treatment, because I'm in New York and that's the one that I'm familiar with. But while they vary by state, their intent is the same, which is to provide orders that can be used outside a hospital setting. So what's on these things? Well, it has a whole variety of things that can be checked, and we'll go into that in a second. But the thing that is important to know is that you can download a MOLST or a POLST or your state's equivalent. It can be printed on bright paper, and it can be brought to a physician for discussion. Now, some physicians will bring this up to patients, but it's also fine for patients to bring this up to their physician. Now, why do we care? Why do we have this thing? Well, I'm old enough that I can tell you that I remember the time when people started talking more about whether it was right to die or right to control their end of life, and the idea of it being okay to be no CPR in the hospital became accepted. So people would be in the hospital and it was clear they didn't want to be resuscitated, but then they'd be in the community and they might have a heart condition or arrhythmia, they might go down, and they'd wake up in the hospital with broken ribs and maybe some anoxia, some difficulty with some brain injury, because they had been out in their home and medical personnel had come by and they had coded them. Because you see, even if you've written it into a legal document, that legal document is going to be in a drawer somewhere. And medical personnel have a fundamental obligation to preserve life. So when they would come in and they'd see somebody who was pulseless, they were obligated to resuscitate them. So what I used to see, and I had a number of clients or patients who had no CPR on their chest, or CPR with one of those circles and a slash across it tattooed on their chest. Well, you know, that's a terrible thing. So people started to realize that they needed to have a way that the EMS people in the field could have medical orders so that they would not resuscitate somebody. And the POLST was born in Oregon, as I mentioned. And so what this MOLST and POLST does is it fundamentally turns a person's treatment wishes into actionable medical orders. Next slide, please. So, and I just want to make sure you have these terms. I think most people know them, but just in case. So DNR, or no CPR, it's usually DNR, means do not resuscitate. A resuscitation occurs when somebody is not breathing and has no pulse. That's resuscitating them. DNI, which is a cousin, is do not intubate and put somebody on mechanical ventilation. So sometimes you see people who may regain a pulse or may have a weak pulse, but are not breathing enough to be able to maintain themselves. And that's when medically we would intubate them and provide artificial breathing for them. And so it's common now for people to be DNR and DNI. And when that first started happening, frankly, people in the hospital used to think that that meant no treatment. And that's not true at all. It's just specific to resuscitation and intubation. Now on most forms, there are in New York, they actually have a box that says no hospital transfer. So you can have a medical order that says if EMS is called, do not take this person to the hospital. There are boxes around antibiotics, IV fluids, feeding tubes, etc. And as I mentioned, if you're DNR, DNI, you can still get oxygen, pain relief, etc. Next slide, please. So how do the living will and the MOLST go together? Well, the living will is a legal document that shares the wishes and designates a surrogate. The living will is the one that's in the drawer. It does not have medical orders. The MOLST is the one that is bright pink or bright orange and stuck on the refrigerator or on the back of the door for people to see. The MOLST does not name a surrogate. It is specifically medical orders for non-hospital personnel to be able to follow. Next slide, please. So how do we use all of these things? Well, as we've touched on several times, privacy. So from a medical point of view in the hospital or rehab or nursing home, it tells us who we can talk to and, very importantly, who we can legally release records to. And this is particularly important for our work as advocates because we often need to take a peek at the medical records of some of our clients. And unless somebody has been named specifically as the healthcare proxy or the surrogate, it can be difficult to get those records because it's a surrogate who can then access those records and then on their client's behalf, release them to you. For treatment wishes, and keep in mind in the hospital or in medical care, what we want to know goes well beyond consenting for procedure. We really want to know how far we should go, what to do or not to do. We want to be respectful of what people want. And then, of course, there's medical consent. And keep in mind, even if somebody is named a surrogate, if you can speak for yourself, of course, we're going to ask you. You will continue to make all your own decisions as long as you can do so. But if you can't, then we will have the surrogate sign the consent. We'll be talking with them. And of course, we read your documents along the way whenever it's appropriate. Next slide, please. And so this is my last slide. I would be remiss if I didn't just bring up hospice, and I suspect almost everybody listening is very familiar, so I'll just touch on a couple of things. Hospice, of course, is care that is available within the last 6 months of life. It is different than palliative care in that palliative care is a broad term that focuses on symptom relief, regardless of the stage of an illness. Hospice is specifically for people at the last stage of an illness. And hospice provides physical, emotional, and spiritual comfort. Physicians are often afraid to bring up hospice, and that's why sometimes your clients or you have to bring it up. Why do physicians fear bringing it up? Partly because they're afraid that families may think that they're giving up, partly because they're afraid that the family may think that they no longer care. And sometimes it's simply some myths and misgivings, even within the world of physicians. But hospice doesn't mean giving up. It means shifting the focus to symptom management. It's not just available for people with cancer. And the good news is that insurance almost always covers it. And included in hospice care are nurses, not 24 hours a day, but nursing support, support for the family, which can be extremely helpful, medications, equipment, supplies, PTOT speech. I've seen art and music therapy, grief counseling. There's a lot of incredibly beneficial things in hospice. And as you see in the last bullet, hospice can be very helpful for the loved ones. The last thing to mention is location. For locations, in the past, hospices were in nursing homes or they were in hospitals. Now, almost entirely hospices or hospice takes place in people's homes. There are still a few freestanding hospices around, but almost all hospice care takes place in people's homes. Oh, and I do have one other thing to mention, tricked you on that last one, which is that hospice, can be renewed. Sometimes physicians are a little bit afraid where they're like, well, I can't predict whether someone's going to die. And what we say is, would you be surprised if this person died within the next 6 months? And if the answer is no, I wouldn't be surprised, then that's good enough for hospice. Then you can say, it's okay. If you wouldn't be surprised, this person might be within the last 6 months of life, and it's okay to order hospice. And hospice, you can stop it. If the person gets better, you can stop hospice. If the person is still dying, you can renew hospice. It's something to really be considered. Okay, and last slide. So thank you very much for your time and attention. I'm Dr. Gerda Maisel from MyMD Advisor. And next up, you have Janice Landis from The Final Exit. Thank you.
Thank you so much, Gerda. That was a wonderful guide through the labyrinth of medical and legal pathways to get where you want to get. Final Exit is a nonprofit that talks about how to ensure that your end options are consistent with your life options, that you can end your life in the same way that you lived your life with autonomy. Next slide, please. The one thing that COVID taught us, which I think was a shock to many people, not just the suddenness of death of people around them, but that people were suddenly thrust into the role of being the surrogate for someone who was young and healthy, and they had never anticipated having to make those decisions for that person. So it's always a good idea to ask the people close to you in family or friendship, people whom you're very close to understand whether they know what they want and whether they've made preparations. And of course, for you to yourself to make those preparations, because once something hits, as we saw, it was a very close time frame from COVID at home, COVID on a ventilator. Somebody somewhere had to look at that person and make decisions who probably never thought about being in that kind of a situation. You can deal, as I often say, with grief. Guilt is much more difficult. If you don't think you made the right decisions for a loved one, it's very hard to get past that. Next slide, please. So we've talked about the fact that Advance Directive is critical to your thinking about what it is you want, how you want it done, what are the conditions under which you want life continued or in which you don't want to continue. Very often, as Gerda has pointed out, you won't be the one making the decision. The healthcare surrogate, and as Gerda said, that has a lot of different names, but in all cases, it means you are acting as if you are that person. And that's the important thing. You're not acting in what you believe to be the best interest of the person. You are acting as that person would have wanted to act if they could speak. You are, in effect, the interpreter. You're not the writer. You are the interpreter giving the talk that that person can no longer communicate in a language that anyone else can understand. And so when you do that, when you name that person, they have to understand that, and you have to understand that there will come a point when medical professionals may say, this person, this patient can no longer speak for themselves. Who is the surrogate? And that surrogate is then legally the person who speaks for you. And it's important to point out that can be temporary. In effect, many of us act as a healthcare surrogate, although we don't think of it that way, when a person has an operation and in the recovery and some extended period in which they're really not capable of saying anything. And they will always ask the family member or the friend, do you think that, this person can go up to their room now? Or do you think this, do you think that? They'll talk to you because they know that person in recovery room can't really make a decision. As soon as they can, automatically and by law, you're not the surrogate anymore. It doesn't have to be any formal transfer of power for this. It's the question of incapacitation that makes for the healthcare surrogate. So next slide, please. Given how important this surrogate is, that they are in effect you at your most vulnerable, what is it that you would want when you pick a surrogate? Well, first of all, surrogate should never be picked just because they're the person that everybody expects to be your surrogate. Your spouse may not be the right person to be your surrogate. They may have their own health problems. They may be in the early stages of dementia. They may be physically suffering in a way that makes it impossible for them to get to the hospital and make these decisions. You may have an older child who is absolutely compatible with what you believe, but they may be at the other end of the country and constantly in meetings from which they cannot be interrupted. So they may not be the right person. You need to make a decision not based on who's going to feel bad if you don't pick them. That is not the basis for the surrogate. You need to say who is going to best be my surrogate. And that means they're going to be available. And that's important. If they're overseas, if they have jobs that constantly call them out from which they cannot be interrupted, they may not be the right person. If they don't have the skills, communication skills, to talk to a medical professional and to understand what the medical professional is saying, they may not be the right person. If they're not assertive, Many, many people, and we see this in our organization all the time, people who are lawyers, people who themselves are medical professionals, when they are serving as a surrogate for someone they dearly love, lose many of their professional qualities and attributes because they are now so enmeshed in the pain and the worry about their loved one. So you need someone who can be somewhat assertive, someone who can think clearly and objectively and rationally about what you said you wanted. And you need to let everybody else know that that is your surrogate. It should never come as a surprise. If you are picking your younger daughter, then your older daughter needs to know and needs to know why. And one very important gift that you can give your surrogate is to have some sort of a family meeting. It can be, a Zoom or about whatever, and say in advance, this is whom I've designated as my surrogate. I know that some of you will not agree with the decisions that this person makes, but I want you to know they are making them based on my beliefs, my desires, and the greatest gift that you can give me when I am ill and can't speak for myself is letting this person speak for me. Do not become the Terry Schiavo, all of these awful cases that wind up in court for years because one person decided they knew better than your surrogate. Get that buy-in in advance as a favor to you as the person they love, that you are not asking them to step in and override your surrogate. You trust your surrogate. The surrogate also has to be someone who is willing to get some unpopular opinions from family. When Aunt Gertrude calls in and says, what do you mean you're doing that? They have to be able to be calm, rational, and guilt-free. When they tell the doctor no more chemo, they have to be able to look in that doctor's eye and say, no, I'm not killing my father by discontinuing him. The disease is killing him. I'm making him comfortable and complying with his wishes. That is not an easy thing to do. And as Gerda pointed out, you're not going to be a medical professional, most likely, but you have to have some knowledge of what these medical choices mean, or ask questions. Why are you doing that test? What will that test accomplish? Will it only confirm what we already know? Then I don't want them to go through that invasive procedure. Why is there therapy if you don't expect that the lungs will ever regain any ability to breathe on their own? Why are we doing this respiratory therapy? What does it mean to go on a ventilator? And can it person come off the ventilator if it's not working? Why are you putting in a feeding tube? And most importantly, can that feeding tube come out if I decide that the feeding tube is not working? The ideal scenario, and I was a surrogate in such a situation, with a person who was semi-conscious and agreed to a decision to have, actually it was a breathing tube put in the hopes that a procedure might accomplish some short-term better quality of life. But we both agreed and told the surgeon that within a certain time frame, if that recovery didn't occur, we wanted the breathing tube removed. Sadly, after a few days, there was no recovery. And I had no problem with that doctor saying, I now want that breathing tube removed, because we had laid out that scenario in advance. And when that happened, contrary to all the stories you hear, I had no problem. The doctor simply required me to answer, do you understand that when this breathing tube is removed, your friend is going to die? I had to make an affirmative statement that I understood that. And once I said that, I stepped out of the room, they did their thing, my friend died peacefully. So you have to understand what's being done and ask the questions before they're done, before things become irrevocable. So those you can, and you want somebody who's willing to ask those questions and capable, quite frankly, of understanding the answers. What is a PICC line? What is a feeding tube? What is what is in this IV? What happens this? What happens then? Ask those questions and then make the decision. And very importantly, it is rarely necessary to give a decision that second. You can have 5 people in white coats standing next to you. You have the right, unless there's an emergency at that moment, you can say, I need a few minutes to think about it and to call a few people and to get some advice, and then I will answer you. And I have advised people to do that, and I have seen that work. You just need to stand up for the rights of the person you are representing. Next slide, please. Issues that may develop. So now I've made it sound like a very easy process, but of course things rarely go strictly according to the script. As Gerda mentioned, and I've mentioned, there can be family disputes. There can be doctors who simply override what you have said. I have seen cases where there were no antibiotics to be given and antibiotics were given. This is not supposed to happen, but it does happen. And it is the job of the surrogate at that point to seek assistance. However, they may have to go to a lawyer, they may have to go to the ombudsman, they may have to go to a social worker at the hospital, they may have to seek out some other resources, but they may have to say, I am the surrogate, I have said no antibiotics, I want the antibiotics to stop. And sometimes that can require a bit of a struggle to get that done because the doctor truly believes those antibiotics are in the person's interest. They're not doing it out of some evil design, but they really can't quite believe that you understand the impact of that decision. You have to make it clear you do. You also have to know that there are facilities that will not accept certain legal provisions of an advance directive. And that is one of the most critical issues that will face families in the current environment. If you go into a religious affiliated hospital or care facility, they will tell you in advance in their rules, we will not agree to withdrawal of hydration and food. We will not agree to it, even though it's legal. We will not agree to take out the breathing tube. We will not agree to shut off the ventilator. If you go into such a facility and that becomes a problem, you may need to transfer the person elsewhere. Religious objections are honored in a facility. You cannot go to court and require that hospital to do something that they have told you in advance they will not do. VSED, voluntary stopping of eating and drinking, is one very increasingly common way that people choose to end their life. It means taking no fluids, no liquids. And for many people who are in an end stage disease, it can be a relatively easy, and I say relatively easy way because their body is shutting down. They don't have much appetite anymore. But there are institutions that will not allow VSED on their premises, even though it's legal. So you need to know that. You need to know if the person has dementia, they're going to be fed by hand, even if you don't want that. You cannot prevent that from happening. And I also want to point out, this is the actual wording of a contract that people have signed that I know never knew they signed when they admitted their person to their family member to a care facility, particularly a memory facility. In the small print of the document, it said, residents shall participate and comply with treatment ordered by our healthcare service providers, including the administration of medications. Failure to adhere to house rules and additional resident responsibilities can be cause for discharge. Read the contract carefully. It may not mean anything to you at the time the person goes in, but if you have signed that statement, that advance directive and your role as surrogate is basically null and void because you have handed over the role to the medical staff. This is a very big increasing problem in medical facilities. Know what you sign, know what that patient signs, look at every bit of fine print and make a decision whether you're willing to abide by that requirement. It does shut out a lot of doors, shut down a lot of doors. Next slide. Okay, so again, we talked about some of the specific examples with problems, but the continuation of unwanted therapy particularly actually occurs most often with things like chemo, where a person is really no longer benefiting from it, certainly with antibiotics, but also it could just be all kinds of interventions throughout the day. Could be psychologists coming in, it could be occupational therapy, physical therapy, all kinds of things. What you want to say in these cases is palliative care. Give that medication if it will make them more comfortable. That is all that is relevant to this person now. But again, you're going to have to be vigilant, and you're going to have to recognize that sometimes they're going to fight you on it. And by the way, sometimes you will have the other problem. They will not give enough pain relief, and you will have to insist on the patient's right to be pain-free. And we've seen those cases too, where pain is allowed to break through. You have to become educated on the right of the patient not to be in pain, and that palliative care can include pain medication that may shorten the life of a person. But if the intent is to simply alleviate the pain, it is completely legal in every state. And you need to fight for that person's right to get the right amount of pain relief. That is, I think, one of the most sacred duties a surrogate has. It's one of the only gifts you can give to a person at that point in their life. Next slide. I'm often asked about whether professional social workers, elder care specialists, anyone in that field can be a surrogate. And my answer is that I think, well, first of all, legally, yes, they absolutely can be. Ethically, can they? Absolutely. In many cases, I think they are the best people to be surrogates. And in many cases, I encourage it for all the reasons I mentioned. You're not going to feel guilt. You're going to feel a strong sense of professional responsibility. You're going to understand the medical landscape. You're going to know how to speak to medical professionals. You're going to possibly know that hospital because you've been there on other cases. So you are not going to be a stranger in a strange land. And that is a huge advantage. And there is something very important in not being able to have a doctor look you in the eye and say, so you're trying to kill your father. That's not a dialogue that's going to occur. And you'll be able to say, I've seen other cases like this, and I see that the best way forward in this patient's interest is such and such. So yes, I think it's a growing need. I cannot tell you how many people, especially as the population ages, single people, and the demographic is particularly single women who have no family that are close to them, and their cohort friends are either also in ill health or dying or dead. They do not have anyone. So if this is something that you can do, and you can provide it at a fee that that person can afford, I think it is an excellent thing. I think it's the wave of the future, and I support it absolutely. But like anything else, you need to specify very clearly what that service involves. If it's somebody who's dying, it's going to be a short-term thing, probably. If it's somebody with Alzheimer's, you've got a whole different story, because that could be a 10-year process. Do they want you physically at the hospital? Are they fine with a phone call? Should you just drop in from time to time, or should you be there every day? And what will that cost? It's very important that that person and their family know what your obligations are, what the expenses are, and what you are prepared to do. And of course, that your ability to advocate for them will not be compromised by any private belief that you have. If they want to fight to the last breath, you have to be willing to do that. If they want to opt out at the first choice they get, you have to be willing to do that too. And if you can, then I think it is an absolutely terrific service that many people need. Next slide, please. Final Exit Network is the organization that I mentioned that I'm part of. We're a nonprofit. We support the human right to a death with dignity, which means on their terms with the quality of life that they want and the quality of death that they deserve. Thank you very much.